Hello, and welcome to Healthy Living. I'm Dr. Donald Pelto, and I'm here with Dr. Harvey Claremont today. He is a retired surgeon from the area of Worcester. Dr. Claremont, thank you for joining us in Healthy Living.
Well, I'm happy to be here.
So tell me a little bit about yourself and about your history. How did you end up in Shrewsbury here? And
Well, starting from at the beginning, you know, I was born in the Berkshires, and in fact still have a couple of my relatives in the Berkshires. I love to go there. But then went on to Holy Cross after high school, and that introduced me to the Worcester area at least. After that, went to Harvard Medical School, and then on to Rochester, New York at Strong Memorial, where I learned my surgery trade. And also did a lot of training in family practice as well. So I could have put my shingle out for anything, really. Then I went into the Navy for 2 years. Actually, they had me running a hospital in Alaska.
Was that after residency?
That was after residency. So I was fully trained. I could have gone to Vietnam. In fact, I anticipated going to Vietnam then. My wife already came back, was going to stay in the Berkshires with her parents. And we had it planned that way. And then all of a sudden got my orders for Adak, Alaska, and I said, where is that? But basically it gave me a little bit of the administrative end of things. So, and I actually loved my 2 years in the military and still have friends from that time in the military. And then back in 1973, moved to Shrewsbury.
Wow.
And set up practice at the Fallon Clinic back then. And that's back with some of the original Fallon Clinic people. And I miss them all. Most of them are gone now.
You were one of the originals.
I think I was number 18, something like that, yes. Yeah.
Was it all, in that day, was it just a group of people, like a private practice?
It was the very first group practice in the Worcester area. And they had a difficult time when you go through their history, difficult time starting up. Then they began to get a couple of internists in, they got a radiologist in, and the practice began to take off. They bought a property over on Plantation Street. In fact, I think they just very recently are going to move out of that. And they're going to all go down to, I believe, around the Greendale area. They bought a big building in there. They're going to put a lot of the practices over there.
Building was probably getting old by now, right? Is that
it's getting old, yeah. And I take it back. The people from here are going to Fairlawn Shopping Center. They're going. They bought the old Price Chopper building.
Wow.
And they're going to move there.
So. Interesting. So then you set up shop in Shrewsbury. Was your practice? It was over at Fallon, and you were living in Shrewsbury.
Correct.
Had your whole career. And now, as we've been talking a little bit, you're just as busy, except taking call, as you were when you were practicing. You're pretty busy right now.
Well, I want to stay busy, too. I've never let moss go under my feet. I've always done that. In fact, that would probably drive me crazy if I didn't have something on the burner ready to go.
Yeah. So most recently, it's been with the Senior Center. You've been involved there. How many years has that been?
That's been since 2000, actually.
Since 2000.
That's when the new building got put up in Shrewsbury. At that point, I had already done missionary work. I did that in Ecuador and Guatemala. I had started then
a couple of public
the
clinics,
program,
right?
Yep, the program over at St. Anne's. And that's still going, actually. I did 20 years there, and that was very rewarding. Very rewarding.
But tell me about that, for those that aren't aware of the St. Anne's Clinic.
The St. Anne's Clinic, when we first started it, I did it with Father Ed Moran. He's since then has passed, but he was very enthusiastic about it. So when I first started it, I actually did some minor surgeries there. We had people bring in all of their equipment that they didn't need anymore. We refurbished it a little, gave it out to people who needed it. I began to take in medications. Of course, not so legal, I guess, when you put it in those terms. But, medicines, that expiration date doesn't mean a thing. Some of them are good for 10 years plus.
Yeah.
And, but you just can't say that, anymore.
Yeah. Even I find to look in the refrigerator and things, they always expire. And so I've been married for about 5 years. And before I got married, everything that was in the refrigerator was almost expired, and I got married and everything got out. But it was good. I never got sick.
No, of course not. And the same with medications too. But so I gave those out. They don't anymore at St. Anne's.
Yeah,
but they'll just give a prescription for a generic drug. And matter of fact, I just gave a talk on generic drugs. I'm going to be giving one at the Greendale Men's Club in September.
Yeah. So what are some key points about, let's talk about generic drugs. What are some key points about generics? Are they the same as name brand? Are they
No, they're not. The only thing that's the same between a brand name and a generic name is the effectiveness of the primary agent that's in there. That has to be the same because the FDA checks that. That's the only thing that's the same. There's a lot of fillers in the medications.
Yeah.
If you actually read the label, you'll see there are things that take up space, the fillers basically.
Yep.
There are things that stabilize it. There are things that color it, because you got to have it appealing to the patient, obviously.
Yep.
There are things that flavor it. There are things that coat it. Depending on what kind of a coating you put in, you can have it either dissolve quickly, like under the tongue, for example. You can have it dissolve further on, like enteric-coated type medications. Or you can just have a regular medication that has a little bit of coating on it. And in fact, the coatings themselves, I've seen pills that have shellac coating the thing. They keep saying that the amount of stuff that's on a pill isn't going to kill you, but when you look at the labels, though, you may find that you may be lactose intolerant, and they use lactose as a filler. So they're not all the same, is the bottom line.
So which ones do you need to make a fuss about?
Well, you make a fuss if you, for example, it's okay to give me a generic drug, but if I am not getting the same effect from that drug as I did the previous one, I go back to the pharmacy and I say, listen, I don't know which of these pharmacies you got it from. And for example, I use lisinopril, damn blood pressure, and there are 28 different companies that produce generic lisinopril. So if I suddenly see my blood pressure starting to creep up, I'm not getting the effect from that lisinopril. I'll go back to the pharmacist and say, listen, which company did you get this latest one from? And I want the stuff that you gave me before.
Yeah, I think that's something we don't even realize, many people. You think a generic's a generic, but it's really not. And
it's really
and they switch it, whoever probably gives them the best price.
That is exactly what happens. It's
like
exactly.
Anything.
You go to the pharmacy, and now they're all big chains, and they'll buy stuff from one of these pharmaceutical companies for the cheapest price. You got the same active ingredient, same dosage, but not necessarily the same.
Those are some good points.
So I always tell the people at the senior center, you got to be your own advocate. You got to watch this yourself. And if you do, you'll be much more aware, and you'll find things like this.
Yeah, and I think it's something that the patient finds. It's harder because you don't see your doctor. You see him maybe every 3 or 6 months.
And you're lucky to see the doctor.
Yep.
You may see a PA, you may see a nurse practitioner. And there's nothing wrong with nurse practitioners or PAs. People have to realize who you're seeing, what their degree of education is, and if you have a problem that's not being addressed, you want to see your doctor.
Yeah. Once again, it's being your advocate, because a lot of people don't have family. A lot of times the family should be the advocate, but may not have family, they're not involved with them.
That's exactly that's true. That's absolutely true.
And something else that we were just chatting a little bit about, I'd like to segue into a condition that's really prevalent with the senior population. It's called dementia.
Yep.
And I'm sure many people that are listening to this, either they have a loved one that has dementia, they may be struggling with some type of dementia. Can we talk a little bit about that, your interest and your experience with that?
Well, obviously there's millions of people in the United States who have the various stages of dementia. Dementia, we always try to categorize things. I don't know whether that's an organizational thing that's part of the United States. We like to organize everything, you know. So they have 4 different stages of dementia. Alzheimer's is only one disease that's part of the whole dementia picture. The first stage of dementia is usually just memory, or it may be at least what they call now cognitive failure, basically, you know, and just to a mild degree. You're not, at that stage, you're not losing your way or things like that. But there's changes, definite changes.
That you recognize, or can you sometimes not recognize?
Sometimes you don't even recognize it, because some of these things, like memory, for example, if you're not actively involving your brain all the time, you may actually develop a form of mild dementia. Not necessarily labeled as dementia, but if you took a test, for example, for dementia, and we do have a number of different tests that you can do. One of them that's my favorite is called a cognitive thing. All you have to do is three different things. Number 1, you give the person 3 items to remember when they first come in to see you. And then you drop it for a moment anyway. And then going to have you draw a clock. And you draw a clock. You're going to put all of the 12 numbers on that clock. Once you put those in, then you're going to put the hands in, and you're going to make it say 10 of 12, something like that. And then you ask them, what are those 3 things that I told you to remember? If you get 1, that's pretty good. You get 2, that's better. 3 is obviously normal. So those are the little things that you can very quickly test.
Yeah.
With the clock and all, it's amazing the varieties you get. And especially when you say, make it 10 of 12, and people start scratching their head a little bit, and where do I put that and all. You know, it's a very good test to do, very quick.
Yeah. Now you were saying this is something that just even not using your brain, it can affect it. Is it based on age, or can younger people have dementia if, I don't know, let me just...
Well, dementia can come on, especially in families, and especially things like Alzheimer's. I don't know if you ever saw that movie on Still Alice. Actually, it was a very well-acted movie.
Yeah.
About a young lady who was a professor at a university who began to show some rapidly progressing signs of dementia. I believe she was late 40s.
Wow.
And it got to the point where she began to really lose sight of many different things. She never took care of herself then. That's usually a later stage when you're not caring for yourself. That was, like I said, it was a very well-acted movie.
So before we go on more, I know everyone's probably curious, as I am. So then, what causes? Is it hereditary? Is it diet? I know I've heard some people talk about wheat and gluten and all these other things and medications.
Well,
do we know?
Nobody really knows for sure. They see these deposits in the brain, these amyloid deposits, and they try to relate it to that. They say, well, maybe if we can find a drug that would dissolve those amyloid deposits, people won't develop dementia like they do. I don't know. I think that's just a red herring myself. So
we don't know.
There's a lot of research being done on it. Yeah. Almost as much as you get in marijuana now, and there's a lot of research on marijuana as well.
Because it's one of those to the forefront.
It is. Unfortunately, mental health doesn't get funded as well as other medical problems.
And it's all about funding.
It is.
If there's no money in it, there's no pharmaceuticals in it, especially.
That's the
It's
big thing.
It's all pharmaceutical run.
Exactly.
They're the ones
Yeah.
that are kind of guiding everything.
Exactly. Yeah.
Wow. So for the dementia, then the first stage is this short-term memory loss.
Short-term memory, and you may progress then to the second stage.
Is it based on time? Is it based on stress in life? Is it you were talking about
All of the above. All of the above. There are some risk factors. People who, for example, drink to excess. People who smoke. Smoking seems to be involved with just about everything.
Smoking's blamed for everything, right? They blame smoking and everything.
And I imagine now they'll blame marijuana for the rest of it, But smoking, alcohol are two biggies. You can get what's called a vascular dementia, where you have hypertension, high blood pressure, untreated.
Okay.
And vascular dementia, in fact, that's what my sister back in the Berkshires has, is a vascular dementia. And she wound up having a stroke. And now we're seeing all of the residual from that. So that is, there are 4 different forms of dementia. Alzheimer's is the most common.
Yeah.
Vascular dementia, second most common. The third is called Lewy body dementia.
Yeah.
And Lewy body is has a lot to do with Parkinson's as well. And then finally, there's a frontal temporal dementia. And that's kind of a wastebasket because it involves mostly frontal lobes and temporal lobes. But apart from that, it's a very rapidly progressing type of dementia. People still don't know too much about it.
Yeah. So what can if I want to prevent it at my age, is it keeping mentally active? Is that the most important thing, being involved?
Mentally active is good. Avoiding excesses like
we talked, smoking, alcohol.
Too much smoke. Yeah, you shouldn't smoke anyway. But if you do, minimize it. Really. And same, moderate alcohol. Moderate isn't going to hurt you, but excessive will.
Yeah.
Keeping in good shape, keeping in good health. Exercise. I've always emphasized exercise. I've exercised all my life. And here I'm 78 years old. I haven't had any heart problems. I haven't had any lung problems. Not that that's, maybe it is a good example of what can happen when you are caring for yourself.
Now, over the years, as you're aging, does your exercise activity, type of activity, change? Or are you doing the same thing now as you did when you were 30?
No. I played basketball and baseball right up to almost age 50. And now I'm doing yoga and Pilates.
less impact.
Yeah, in fact, I teach Pilates.
Over at the senior center.
Yeah, to seniors.
Wonderful.
We have a chair class actually, and for people who have disabilities. They may have had a hip done, a knee done, a shoulder done.
Make modifications for it.
And they can't get down to a mat.
Yeah.
And so we do it in a chair. And but I also have a mat class too that I love.
Neat. And the other aspect we were talking a little bit about was this aspect as people, I think a lot of the conditions we're aging, people really don't know what others are feeling like. So you told me this about walking in others' shoes. So tell me a little about
that's a great program actually. It began roughly about 15 years ago.
You started it, or it started?
No, I can't take credit for any of that. No new things come from this mind, But I can recognize when something is a good thing
idea, and
run with it. Walking in your shoes is a sensory deprivation course. What we do, and a lot of seniors have sensory deprivation. The senses are vision, obviously, so we put yellow glasses on to mimic, for example, cataracts. They also have some glasses where little cutouts, little imprints are put into the glass so that you have a cutout, like you would if you had macular degeneration. Okay. Put earmuffs on so you're not hearing as well. Now that doesn't exactly conform to what happens when you're older, but it cuts down on your hearing.
Yeah.
So That's another sensory deprivation. Put gloves on the hands. They're thin gloves, but we tape a couple fingers together so that you're limited in your motion in the hands. And then and then the last thing we do is we put inserts in the shoes so that it mimics a neuropathy and affects your balance a little. So then we give the people some tasks.
You do all this, you do everything, or is it one at a time?
No, put it all on. And then we give them a few tasks.
Yeah.
And we may even give them a task like doing that cognitive study, with the clock and picking up things. Yeah. But we have them try to pick up something, try to write their name or something like that. Diminish the volume of your voice so they can barely hear. Also, like I said, picking things up. And then walking. See if you can walk a straight line, for example, that type of thing. Some people have difficulty walking a straight line just with normally, and so then afterwards, we'll have them take the things off and then sit down, we'll talk about it. What did it feel like to not be able to see as well? What was it like when you couldn't really use your hands to do a simple task, for example, like signing a check or whatever it was, And it opens their eyes.
Has to be pretty frustrating, I would guess.
It's got to be frustrating, it has to be. So we're going to do that actually on the 29th of March.
So those that want to go?
At the Senior Center.
At the Senior Center.
It's open to anybody. You don't have to be a senior. I look upon it as something that is good for caretakers.
Certainly.
Because they're dealing with somebody who has some sensory deprivation. I want to make sure that they at least get the benefit of knowing all the things that they need to know as a caretaker.
Yeah.
And in fact, the little spiel that I give at the beginning is specifically to the caretaker. We call it a COPE mechanism. Learning to communicate with the person, organizing not only the person's life, but your life, because caretakers are notoriously, they don't take care of themselves.
They're so busy taking care of the other person, they forget about themselves.
Exactly. And then the last thing is make sure you exercise. That's the E part.
Yeah.
So this is the sort of thing that I would like to see a lot of people come to that, especially the caretakers, because like I said, I emphasize it for them.
Because those are the ones that are taking care of these people with these difficulties.
That's correct.
They're the ones that are on
correct.
the front line, family members normally.
Right. And then plus we are hoping to get Shrewsbury to be a senior dementia-friendly community.
Yeah.
A lot of communities around here are already dementia-friendly. For example, Westboro, Northboro, Auburn, and they started this years ago, 4 years ago.
Is it a certification the city needs, or a course, or pay a fee?
There is a little course, yes. And but we're trying to develop a little training program here so we can go into the businesses, for example, like say a restaurant, and you get somebody in the restaurant who may have some dementia, and that happens. It happens. How do you deal with that person? So I think it's a good thing. It's a very good thing for a community.
And who makes that decision in this community?
Well, we're taking it upon ourselves.
Okay.
We're doing it ourselves, and who better to do it than the seniors?
Correct.
Let's face it.
Those are the ones that are affected mostly.
They're the ones that are mostly affected, and so I don't wait for people to do things for me. I've always been that way. If something looks good, do it.
Just do it. Just do it.
And then take the consequences later.
Either the good or the bad.
The good or the bad. That's right.
The good or the bad. Well, I figured we could finish. Part of the sensory aspect, it can kind of make people more prone with the hearing, with the neuropathy, with falls and preventing falls. So I'd like to kind of, as we finish up here, talk a little bit more about falls and preventing falls and things like that, and your work with that. Well,
I have a nice handout that I give to people. We're going to do fall prevention in April.
Okay.
So this is the March program, is the walking in their shoes. The April program has to do with fall prevention. And you prevent falls, first of all, in the house.
By taking away the rugs and the
Yeah,
trip
and
hazards.
all of that. You go to the bathroom, make sure they have something to grab onto. If you need a seat, get them a seat. Make sure you don't have to step up over a high tub, for example, to get in and out. There are seats that sit in there that go over that wall, you might say. And so that's a simple way of doing it.
It's house modifications.
Right. Bedrooms, especially. People who are on medication, they may take some of their medicine in the morning and some at night.
Yeah.
And they take it at night thinking, well, I'm going to be sleeping and all, no big deal. But then you got to get up to pass your water in the middle of the night.
Yeah.
Make sure you have a night light so you can see where you're going. So all these little things in the house. The one good thing about a house is that at least you have a flat surface you're walking on.
Yeah.
And usually decent lighting, and that's another thing that we have on our sheet. Outside, it's not a nice flat surface usually, so it's an irregular surface. That's where you need your balance, and so exercise is the key to that.
Hence the Pilates and the yoga.
Pilates, yoga. A lot of the physical therapy places now have a program for balance. And some of it may be because people have vestibular problems in their ears and they lost their balance that way. And they have a lot of them have the vestibular programs too, besides the exercise
But
balance.
a lot of it's due to the musculature too, getting weak as we get older, the core strength reducing.
In fact, the biggest argument I ever have with physical therapy is that when somebody goes there, for example, if you broke a leg or something, you go there for that leg to get that back into shape again. They forget about the rest of the body. You've got to exercise the whole body so that you're not imbalanced.
They seem to be so focused on just on strengthening that one extremity.
And that's because the darn insurance only pays for that.
They will. So if they're there seeing for a shoulder and you have to look at the leg, you have to go see two different people or come twice. It doesn't make any sense.
That's right.
It's all insurance.
That's right. Yep.
It's all insurance.
So we're going to do that in April, and we're going to give a little talk, and we're going to have a demonstration on the exercise stuff. We got some people from the Greendale Physical Therapy right down here on Route 9.
Route 9.
They're going to come up and demonstrate their program, and that's the second Thursday of April.
Well, very good. So for everyone watching, we have a program in March and a program in April. Dr. Claremont will be doing that. And once again, thank you for joining us.
Boy, that went by fast.
That went by fast. We're already done. So we'll have to do it again.
Okay, please. Yeah.
Thank you.
Okay.